follow-up of the patient. That is also important in Indian scenario, that how when we call these patients and what are the criteria of calling these patients back, because many patients don't turn up for follow-up please, or they cannot afford to come down for follow-up please, not as if they don't want to come up. Next, please. As we have already covered the focal and scattered laser photocoagulation, so my talk will be more specific for two things. One is focal laser photocoagulation, another is for scatter laser photocoagulation. Once we are doing a focal photocoagulation for diabetic macular edema, the possible transient initial decrease in the central vision is very important parameter. The paracentral scotoma laser burn have been placed very close to fovea. In such a case, the permanent central scotoma may be there. So we must look for a follow-up patients for these things, the permanent of the central scotomas, and we should avoid inadvertent any foveal burn near to, because once we go very nearer to the retina, that should be. And I think micro or sub-threshold micropulse laser will be an answer for treating this, where the chances of collateral damage is minimal. Thus, we can save the macula and avoid inadvertent damage to the macula. Once we are doing a pan-retinal photocoagulation, again, because we are doing the pan-retinal photocoagulation, the patient may develop macular edema, so it is advisable to, in a follow-up, instead of going in a one go, it should be done in a 2 to 3 sittings, or maybe preferably 4 sittings, so as to avoid the macular edema, because the patients come with a good vision or with reasonably good vision will end up into a very poor vision because of the macular edema, post-laser macular edema. Peripheral field constrictions occurs due to pan-retinal photocoagulation, and it is leading to delay dark adaptation. Vitreous hemorrhage, if neovascularization is present, it is a matter of concern. And nowadays, with the advent of other people are more proficient as far as doing the surgical procedures. Otherwise, there was a term being coined in a case where a vitreous hemorrhage has occurred. In case of doing pan-retinal photocoagulation, the term is called a visible laser photocoagulation, meaning thereby you are doing the laser photocoagulation wherever the retina is visible, and wherever the retina you cannot see because of the hemorrhage, retinal or vitreous hemorrhage, you don't do it, because the next sitting maybe that vitreous hemorrhage or retinal hemorrhage will resolve, and patient will be much benefited and does not require any vitrectomy procedures to be done. As it has been mentioned, it will be reduced accommodation and mydriasis will be there in these patients. More important, before coming to the follow-up is how to monitor it, because we should have a proper record so that we know that in this area, say first sitting, second sitting, third sittings are being done. So the keeping the record is very important, and monitoring of IOP is also important, because sometimes if we are doing extensive hemorrhage, there is an increase of intraocular tension as well. So not as if the patient landed into the glaucoma. Record keeping, as we are doing conventional record retinal detachment charts are there. Likewise, ROP chart is there, retinopathy of prematurity, where we are using a diode lasers to do it, because the record keeping is very, very important, so that you know that this area is there. I have come through one of the things where you can keep the records, and instead of mentioning and 1, 2, 3, because many times the patients get worried about that what is 1, what is 2, it is that it can be denominated as a alpha, beta, gamma, theta, and epsilon. That denominations are as for the number of laser procedures being done or laser sittings being done. So a surgeon comes to know better. Instead, that patient is worried about that this much laser is being done. Instead of putting a 1, 2, 3, it can be put into a Latin word like alpha, beta, gamma, theta, delta, and epsilon, and so on, so on. The very important aspect as mentioned that our aim is of the laser in the case of diabetic retinopathy or BRVO or CRVO is to achieve the end stage. What is exactly the end stage or how the laser helps? Laser will be showing the regression of the disease process by blunting the vessel tips, shrinking and disappearing of the new vascularizations. It will often leaving as a gauze vessels, regression of intraretinal microembryos, decrease venous changes, absorption. As I have already mentioned this many times, after doing laser photocoagulation, a retinal hemorrhages or vitreous hemorrhages get absorbed. Contraction of regression of the vessels associated with vitreous separation can precipitate the vitreous hemorrhage because the vitreous separation can put a pull on the vitreous cavity can lead to vitreous hemorrhage. Patient should remain under observations because many times the recurrence can occur. So additional or more or filling up of the PRP is required in these patients. So it is important to note these findings as far as your chart is concerned, these findings in follow-up, please, so that you can achieve the end stage. The review is depending, what exactly the ending review is depending upon the severity of proliferative diabetic retinopathies, requirement of the successive treatment, application of initial treatment should be fractioned as I mentioned 2 to 3 sessions or even 4 sessions or so, looking into whether you are not causing iatrogenic macular edema. Once adequate number of burns is there, then in these cases, patient can be required to see after 4 to 6 weeks or even after 3 months with a perfect control of this. With this, I think a strict follow-up record keeping is also very important. No doubt, undoubtedly, a good laser is a requirement of a diabetic retinopathy of a CRVO or BRVO case wherever you are required to be done. But a proper record keeping and follow-up is also equally important. With this comment, I finish up my talk. Thank you, Dr. Kamalji.
Sir,
Yeah.
for a wonderful lecture. And you can invite the next speaker, sir. We'll have the
Okay.
questions in the end, sir.
Yes, yes.